My name's Tony Griffiths. I'm a gynecologist and I enjoy evidence-based medicine and statistics. And what I've been asked to do for about 20 minutes is to talk about uterine polyps, which seems an unusual topic for a gynecologist, I suppose, in some ways. But whenever I attend conferences, if I go to obstetric lectures, frequently the talks are about antepartum hemorrhage, postpartum hemorrhage, third-degree tears, even common themes. And yet when I go to gynae lectures, we often talk about rare things, the application of robotic surgery with niches, all sorts of things. But we often forget the common and what we call the simple stuff, I suppose, and that's probably to our detriment. And here's one of the reasons why. Imagine there is a society of anecdotal medicinists, our oldest medical society. You don't need to waste time reading journals, you don't need statistics, you don't need numbers, you base all your work on one previous experience. This is what Dr. Google would support. And what an awful society. But the sad thing is, we are all default members of this society. We know that 60% of what we do doesn't work, and yet we still do it. And about 20% of what we do actually causes harm, but we can't stop doing it. So what I want to do is just give you a quick sort of case history, really, and then we'll talk about what questions this patient would tend to ask. Mrs. Talwarts, the humorous name of Mrs. Jenny Talwarts, is a medical negligence solicitor. She's one of these aspiring professors of gynecology, comes to your clinic, and without a doubt, she already has decided she's the expert. A recent scan has showed a uterine polyp. She comes with a load of internet papers, a pen and paper, and you're expecting misery now for the next 30 minutes. So I must admit, with this lady, I would be considering what questions would she ask? And often patients ask questions that are entirely reasonable, but they sometimes get us on the back foot. I would have her consider these questions, sometimes not in order. I've got a polyp, doctor. Do I need it removed? What is a polyp? And why have I got one and my friend hasn't, for instance? Are you sure it's a polyp, doctor? Could it be something else? Is your scanning correct? Are they benign? A common theme, for instance, are they benign? Often ladies come and see me and say, my friend had a polyp in a colon. She's dead. And we have to explain the implications of polyps, nasal polyps, etc. are different. Can they be treated medically? That's an interesting question, isn't it? I bet you never thought about that one. And how do we remove them? Or more importantly, how should you remove them? And a reasonable question is, when will they come back? So if we were a non-evidence-based practitioner, which we sadly are, we would probably answer in this way. What is a polyp? Well, it's a dangly bit of flesh. Why have you got one? Who knows? It's chance. Are you sure it's a polyp? Probably. Is it benign? Probably. Do you need it removed? Probably. Can it be treated medically? Don't think so. How do you remove it? The majority of people still use polyp forceps. I'd use polyp forceps. And that's obviously not the way to do things. Will they come back? Who knows? But I think we can give much, much better answers to this in a more evidence-based way. So what is a polyp? Well, it is hyperplasia of glands and stroma, and it tends to have a vascular core within it. Most textbooks start with really the etiology is unknown, but there has been significant developments. Certainly it's a close relationship with the endometrium, so there's often a global change. And the mechanism that causes polyps is the lack of apoptotic regulation. We know there's overexpression of estrogen and progesterogenic receptors, but one of the strongest models at the moment, there seems to be upregulation of vascular endothelial growth factor, increased capillary growth. And as you know, vascular endothelial growth factor is vital for embryo development, certainly even oocyte development, but it's often seen in pathological areas, diabetic retinopathy, malignancy, etc. So we see an upregulation of vascular endothelial growth factors. With this increased blood supply, there's an attraction of beta cell lymphocytes type 2, and these inhibit apoptosis. There's also some genetic reasons linked with that. There's also good evidence as well with increased blood supply or increased blood flow. There's a migration of mast cells into this area, and essentially chronic inflammation develops. There's some really interesting research in looking at 3 populations in fertility: ladies without a polyp, ladies with a polyp, and ladies with a polyp with inflammation as well. And ladies with inflammation tend to do not so well in terms of implantation. So there's a strong link between inflammatory change and polyps. So is there a relationship between endometrial polyps and obesity, and which you would think, since we know obesity is a major problem for us in terms of endometrial cancer? And there is. We've known this for some time. Previous studies have suggested there wasn't a link with diabetes or hypertension, but actually there's some really good work now looking at cross-sectional data, and there does appear not only to be a link with obesity, as you can see in this slide, the odds ratio is about 4, a mild link with increased glucose, but a fascinating strong link with dyslipidemia and also metabolic syndrome. So actually, when these ladies come and see us and say, why have I got a polyp, not my friend? Perhaps we should be looking at general life and looking at obesity and looking at hyperlipidemia, hypertension, etc., and saying, well, actually, this could be a surrogate marker of cardiovascular disease, which obviously is still a bigger killer. So there is a link, and there are lifestyle changes that could reduce your probability of polyps. Are you sure it's a polyp, doctor? Well, this is a really good question, isn't it? And this lady came with a scan suggesting a polyp. And our best data, we've got a lovely systematic review of transvaginal scans that looked at ladies with symptoms, abnormal bleeding in the premenopause. And Farquhar's work said, well, actually, yeah, you can use a vaginal scan, but here's the beast of it. Its specificity at best is 50%. So you're literally throwing a coin in the air and guessing, the same as our clinical diagnostic skills for appendectomy are shocking. So even in the best hands, so Dava Jurovic looked at vaginal scans. So these are really fantastic experts in scanning, and they could get a specificity of only 40%, but a pickup rate of around 80%. So again, ultrasound scan, even in transvaginal scan, and even in expert hands, you're 50% of the time you're wrong. It's not a polyp. And this you frequently see. So often people who use scan and say, you may have a polyp there, I'm going to do a hysteroscopy, frequently find the hysteroscopy negative, which of course is a waste of health resources and a risk of a procedure and the unpleasantry of a procedure. So what should we do? Well, the evidence-based answer is you really should use saline infusion sonography. And there's a wonderful analysis which has gone through many years really comparing the sensitivity and specificity of 2D saline sonography. Saline sonography is very easy to do. You can put a catheter in the uterus, introduce some saline and do a scan. There's even some of my colleagues use Instilla gel because you don't require a catheter. It stays within the uterine cavity while you scan. This is interesting. And again, sensitivity is remarkably high, over 80% in most studies. But look at this, the specificity, it really picks them up. It's over 80%. Brilliant. So then it was kind of interesting. People said, well, 2D saline sonography is very easy to do. The reps came with the ultrasound machines with 3D and said, well, 3D surely is much better, generates lovely, beautiful pictures, so it must be better. So why not invest in a new machine? Well, actually, yes, the sensitivity and the specificity is indeed fantastic for 3D saline sonography for the identification of polyps. But here's your problem, really. And there's two things on this slide I'm going to show you. As we've said, with normal transvaginal ultrasound scan, the sensitivity is not bad, really. You're picking up 70 to 80%, but your specificity is poor. So if you did a receiver operative curve, remember that the closer you are to this area, the better the test is. You're only around here, whereas 2D saline sonography is a really fantastic curve. So as a diagnostic test, you rarely get a curve this good. You're getting sensitivities of 90%, and look, you're still maintaining your specificities of 90%. The red line represents 3D, so 3D is better, but almost the problem for 3D in some ways is that 2D saline sonography is so good, you don't need this extra bit. It makes very little difference. And if I haven't been able to sell that to you with a statistical reference, I'll show you with a pictorial way. An ultrasound scan, saline sonography clearly demonstrating a polyp, and in 3D as well. Well, it's a polyp. I mean, it's kind of obvious, really. You can't miss it. Certainly the gold standard at the moment is 2D saline infusion sonography. And if you would put the argument hysteroscopy is the gold standard, I would put to you, which would you rather, madam, a saline infusion sonography or hysteroscopy? I know which I would pick first. So the next question this lady asked is it a cancer, doc? And if she hasn't asked it, she's thinking about asking it to you. Well, we've got some really good data for this, surprisingly. 35,000 women were studied in a large review in a meta-analysis and showed actually the prevalence of malignancy in the polyp is about 2.7%. But the problem with this, it's a really heterogeneous group, and that doesn't really give you the right answer. For instance, the rates within the premenopausal women is just over 1%, but in the postmenopausal women is nearly 5%. The risk of malignancy is much higher in the symptomatic 5% versus the asymptomatic 1.8%. So what predictors can we use? Well, size of a polyp, the overall length, significantly increases the risk. If you're postmenopausal, that certainly increases the risk. If you've got abnormal bleeding. There's other interesting things looking at polyp diameter. There's some work on blood flow and elastography, so using some ultrasound features. But all these are independent variables. So, for instance, that would if you've got a large polyp, you're postmenopausal with abnormal bleeding, that's bad news. Your chance of malignancy is high. It's much more than 1%. So size is important, and that's kind of a really useful thing. And you often say people record polyps on ultrasound, but they don't give you the dimensions, the location, the diameter, the blood flow, and that's what you'd expect really from a good quality scan or saline infusion sonography. So what about risk of malignancy? We'll look a bit further really. Shoshan wrote a really fantastic paper, and this was 2004, it really was excellent. And the reverse is true. What if you're premenopausal, you've got a polyp less than a centimetre and you've got no symptoms? Well, in that series, there was a malignancy rate of 0. So it's kind of quite reassuring to say to ladies, there's never a 0 in medicine, but it is as close as you can be based on this series. So what treatment options? Like everything in medicine, there's always 3 treatment options. There's conservative, medical, and surgical. And of course, as surgeon, we really can't wait to get our hysteroscope or resectoscope out, but actually we should discuss the other 2 with everything, really. The obstetrician and gynecologist, our CPD Journal for the Royal College of Obstetricians and Gynecologists, suggested this was a reasonable way to manage polyps. You diagnose them, if they're asymptomatic, that you're premenopausal and it's less than a centimetre, you could consider observational treatment. Leave it there, sit tight, a conservative strategy. And there's certainly big variations in the world in which country you're in, what happens. In the US, you virtually always get your polyp removed. If you're in France, you frequently get it left there. UK is a bit of both. But how good is the evidence to support leaving polyps there if we say the malignancy rate is close to 0 and you're asymptomatic? So looking more closely at the evidence to justify that really, the Obstetrician and Gynecologist CPD Journal suggested there's a natural regression in half of all endometrial polyps less than a centimetre after about 2.5 years after scanning. But here's your problem. The lack of evidence, if you look more closely at it. This was based on 64 patients, but only 6 polyps were seen at the start and 2 at the end. So it's such a small population, I don't think it's reasonable to make that assumption. There was also a case series published as well, but actually this was only of 3 cases, so the evidence is extremely limited. We've got no randomized controlled trial evidence. We've got no prospective studies and very limited retrospective series to suggest conservative treatment is valid. And if you're really bored, these are the 2 references. You're more than welcome to read at your leisure. What about medical treatment? Well, this is very interesting, I suppose. We've got no good evidence. If you look in trial registries at the moment, there's some really fascinating work being underdone, mainly with the use of a variety of progestogens. This was probably the best to date, using the Mirena coil in a randomized controlled trial in women treated with tamoxifen. And we found in women who were treated with tamoxifen, there was a significant reduction in polyp formation, about 1.8% versus 15%. But of course, this is prevention and not treatment of a polyp. And of course, this is a tamoxifen-induced environment, which is probably different again, and you couldn't really extrapolate this to other populations, perhaps. How should you carry out a polypectomy? And many options available, but it's worth considering 60% will occur within 4 years, and this is usually due to what procedure is used. Sadly, even in the UK in our last survey, polyp forceps is still the most frequently used, but we know polyp forceps essentially grabs the polyps, twists the polyps, and fractures the polyps halfway along its length, and essentially the base is still there. So it's not a surprise 60% recur. I say recur, i.e. still present and has been re-imaged. Curettage is also equally an inappropriate way to do things, because once you start using curettage or polyp forceps, you're left with this, the Japanese flag, or the hysteroscopic view you tend to see is a cavity full of blood. You can do then little afterwards. So if you use a grasping forceps, you get at least a recurrence of 15% at 12 months, but if you use a resection or resectoscope, it's 0% at 12 months. And what about new technologies? This is just one of the previous examples. I don't think it exists anymore. In fact, it's VersaPoint, a bipolar device. The reps came and sold us and said this must be a wonderful thing. It glows in the dark. There was a green glow from it, so you can look like Yoda, a Jedi Knight, so it must be great. But of course, there's no randomized controlled trials performed. Morcellator is our new technology. It's small, it gives you good views, you don't get bubbles, but is this really a problem? Is electrosurgery really a problem? Is hyponatremia really a significant problem in outpatient operating? And then often reps and publications have suggested there's shorter operative time. And there was two lovely studies. Mark Emanuel did a very nice study. It was a retrospective study. He found it was quicker to morcellate rather than use a resectoscope. But Mark Emanuel is a hysteroscopic expert. So a better study perhaps is a randomized controlled trial, a stronger level of evidence, using residents. And again, we found that morcellation was indeed quicker than resection. So there is at least time. I don't know if you recognize this man. This is Archie Cochrane of the Cochrane Library fame, and I bring him up for two reasons. One, he's from Cardiff. His research was based in Cardiff, just down the road from me. But he said two things. We must have prospective studies, and we must have more randomized controlled trials, please. And this is certainly the case for treatment of polyps. There's hysteroscopic snares. Again, these came popular at some time, but again, lack of randomized controlled trials or prospective data. But I've told you bits about the lack of evidence. Now I'll give you a little bit about what we do have as tools for evidence. The OPT study was a brilliant study done by Justin Clark in Birmingham, etc. And essentially you wanted to look at this multi-centered way, is outpatient removal of polyps as effective or equivalent to inpatient? And the answer is yes, sort of. But there is a failure to completely remove the polyp was higher in outpatient operating, about 19%, versus 7% for inpatient. Powerful data, and of course we must tell patient this in decision-making options. There's other data we can also explain to them as well. This is something called the SHINE research project we did in Cardiff, and we looked at a population of ladies, and essentially we use a resectoscope, a reusable 10mm resectoscope, and we looked at pain, application of the Valcellum, Cytonest we use as an injection, and often what people are surprised about, dilatation to 10 Hagar, actually is quite a low VAS score. It's relatively painless after Cytonest. It's about 2 out of 10, whereas actual resection of the polyps is about 2 out of 10. The overall pain of the procedure is 3.5 out of a VAS score of 10. So actually it's very tolerable. And globally, when you look at this whole data, most ladies say it's about 3.5 to 4 in terms of pain. But of course, there are outliers. And rarely we get ladies who said it's the worst pain ever, 10 out of 10. And it's important to identify these ladies beforehand and to stop in a timely way. My penultimate slide is I've tried to sell you using a reusable resectoscope in the outpatient setting. This is day care surgery, the second column along, which is very, very expensive under general anaesthetic. The purpley colour is staff costs. If you go from day case to the local, you've significantly reduced the costs. But your ultimate drive, I would put to you, is to move from day case to SHINE, which is outpatient operating, but with reusable kit, such as a resectoscope. There is a drift, unfortunately, from going from day case surgery under local to outpatient operating, but using relatively expensive disposable kit, and that's not a bad thing in itself, but you've lost your cost savings. You've invested your money in buying a product where, I hope I've tried to sell it to you, that a resectoscope you can do, and there's significant cost savings. So finally, let's re-answer some of these questions from the start of the lecture. Do you need to remove the polyp? Well, actually, our evidence is extremely limited to 0 for regression of natural polyps. What's a polyp? Well, we've explained that. Why have you occurred it? Perhaps it's related to obesity and hyperlipidemia, and perhaps we should consider a more global women's health when we meet ladies with polyp and just not treat the polyp. Are you sure it's a polyp? Well, if you had SIS saline infusion sonography, I'm 95% sure. If it's a transvaginal scan, I'm only 50% sure. Is it benign? Well, that depends on a variety of things: symptoms, postmenopausal status, and size of polyp. Can it be treated medically? We've got no good evidence yet, but there are some excellent trials underway. How should you remove them, or how do you remove them, or should you? You should use a direct visual mechanism, and certainly not polyp forceps, and certainly not re-curettage. But I would put to you, from an economic point of view, an acceptability point of view, I would suggest is bring back your reusable resectoscope to our patients. Highly effective, and it's green. Will they come back? Well, this is highly dependent on the mechanism you use to remove them. If I haven't convinced you with some evidence-based medicine to use a resectoscope in outpatients, I welcome you to come to my lovely city of Cardiff and come to our outpatient operating suite. Many thanks.